to join in. Just if you don't mind, just wait for 2 more minutes and we'll start the presentation.
So we are waiting for who? Sorry.
No, nothing, sir. We'll start, sir.
Sure. Go ahead.
Yeah. Yeah. So good evening, everybody. Today the topic is radial access DSA and the technique of radial access DSA. And it is my pleasure to invite today's chairperson, Dr. Kalyan Sajja. He did his MBBS from Siddhartha Medical College, and he did his neurology residentship from Creighton University College School of Medicine, and also from the University of Nebraska Medical Center. He did his vascular neurology fellowship from the University of Minnesota Medical Center, and he did his endovascular neurosurgery fellowship from Thomas Jefferson University Hospitals. And he is currently the Chief of Neuro and Cardiac Cath Lab Services in Life Hospital in Guntur. So welcome, sir, and thank you for taking time out of your busy schedule for this presentation. So I'm not going deep into... Just a second. Yeah, I'm not going deep into the access part of it because that was dealt by my colleague, Dr. Jayashankar, in previous presentations, which is available in YouTube. So the catheter we use for the radial DSA is 5' SIM2 glide catheter. During our learning curve, initially we were doing a lot of angios with SIM1 glide. We were having some difficulties, but later when we switched over to SIM2 glide, things became much more easier. And the cocktail that we give is 100 milligrams of nitroglycerin and 1000 mg of heparin. We generally don't give any calcium channel blocker. And the sheath is 5 French ready focus for the cerebral angios. And till now, among the angios, among almost 170 angiograms, 2 we have converted to femoral. That too, it was initial part of our learning curve when we were doing it through SIM1 glide. So after we switched over to SIM2 glide, till now, we have not converted anything to femoral. So initial part, what we do is generally we take a radial angiogram or a roadmap. There are 2 advantages with this. One advantage is you can see whether you are going into the correct vessel or whether you are going into the aberrant radial. And also you can maneuver the wire easily. And also you can see if there is any spasm that has been induced by the puncture itself. When you do multiple punches, initially there might be some spasm. So it also helps you to maneuver the wire and catheter through the radial artery. So we initially take a radial roadmap through which we take the wire. So the most important part of the radial angio with SIM glide, particularly SIM2, is first the SIM curve reformations. So there are multiple methods with which you can form the SIM curve. So number 1, you can form the SIM reformation in the ascending aorta. That is, when you introduce the wire, it hits the aortic root in the ascending aorta and then it takes a curve. So you can maneuver the SIM1 glide, SIM2 glide, and it forms a curve. Then you can take the wire out. Now it is the curve is formed. So how in angio, this is what it looks like. It is now hitting the aortic root and it has taken the curve, and you slowly maneuver the catheter on top of it. So you see that we have taken the wire, it's almost placed in the subclavian, and now slowly we are pushing the catheter over it, and then we slowly remove the wire so that the SIM takes the curve. So this is one type of forming the SIM curve. Now we have taken out the wire. So the only thing that you need to be careful of is sometimes maybe during tortuous vessels, suddenly the wire jumps into the ventricle, LV. So then what you need to tell is the technician who is following up or taking care of the monitor that it induces arrhythmias. So whenever you see an arrhythmia on the monitor, it shows you that the wire has jumped into the LV. So immediately you need to remove the wire and the catheter to the ascending aorta and then try to maneuver it again. So if at all this happens to you multiple times, in spite of trying it again and again, Then another thing is to take it into the descending aorta for the SIM reformation, SIM curve reformation. So the second, suppose if at all you are encountering this problem, then what sometimes we do is we take the wire further distally, either into the carotid, either left or right, whichever way the wire is maneuvering, just keep it a bit distally and then try to pass the catheter over it. And then you can slowly remove the wire out. So this sometimes might help you, this maneuver. So this is one way of preventing the SIM into falling into the LV. So another method is the SIM reformation in the descending aorta. So this is where you pass the wire into the descending aorta, then you pass the catheter over it, and then you remove the wire. And what you do is then when you are slowly, you need to pull it out and just twist it simultaneously so that it takes a curve within the aortic arch. And this is the shape that it takes. So I can just demonstrate it in the angio. Now, what we did is first you need to pass the wire which has gone into the descending. Now we have taken out the wire, and you can see that by pulling and twisting, it slowly takes the curve, and then you can push it down so that it takes the SIM curve. I'm just slowly pushing it down. So now it has taken the SIM curve. So this is another method of forming the SIM curve. So another method of reforming the SIM curve is in the right common carotid artery, where sometimes maybe 2 to 3 out of 10 times when you twist the wire near the CCA itself, it slowly directly goes into the right common carotid artery. Now you can just slowly maneuver the catheter inside the right common carotid artery and then just take out the wire. You can complete the angio also, and then when you want to form the curve, you can just push the catheter into the arch. So this is where you see the wire is directly going. I can show you the angio. Whenever it is taking a loop and going, most of the times it would be the right CCA. You need not get confused that it is the vertebral artery. So slowly you can push the catheter in and you can just take out and finish your shoot. And now it has already formed a curve. Then you can slowly push the catheter into the arch. So this is one way of forming the curve. Yeah, now if we push, it just slightly comes down. So another way of reformation is it in the left subclavian. So whenever, as you saw in the previous video, we formed the curve in the, we twisted it in the subclavian and it slightly immediately hooks in the subclavian. Then you can take it out of the subclavian so that the curve is formed. So this is one way of forming the curve. And if at all you have a bovine arch and where there is a common origin, or whether it's a true bovine arch where the left CCA is originating from the brachiocephalic, what happens is when you push the wire, it directly passes into the left CCA, and then you can just push the SIM to glide directly over the wire and just take it out. You can finish the shoot, and after finishing, you need not form it again. If you just slowly push it down, it just with the curve, it goes into the arch. So you can see here that the wire has passed directly into the carotid and we have pushed, and you can see nicely the curve that has formed in the left CCA. So this is an angio example where we are pushing the wire, and slowly you can push the catheter over the wire and cannulate the left CCA and finish your angiogram. Then you can complete your shoot. And also same, this is also an example of the bovine arch where the wire directly goes inside the left CCA. You need not maneuver or form an arch. And now you can see that the SIM has taken a curve, and you can take the wire out, you can finish your shoot and slowly push it down. So this is one way of doing it. Just you can see that once it is hooked, just slowly push it with the curve down, and then it goes into the ascending with the curve. So another method of reforming the SIM curve is in the right CCA, which we have seen. So how to cannulate the right CCA. Now you have finished forming the curve in either of the vessels that I have described. Now we are trying to hook the right CCA for the shoot. sometimes it does not go directly into the CCA. So when you're forming the curve, try to approximate the SIM2 so that both the sides are close to each other. Then when you slowly pull the catheter up, it slowly goes up and hooks into the right CCA. If at all it's not going directly, this is the best method, and 99.9% of the times it directly goes into the right CCA. So if you see this, now we have taken the curve in the ascending and we have approximated both the sides or both the tips of the SIM2 together. And now we are slowly pulling it out. And when you pull out, invariably, most of the times it goes into the right CCA. So then you can finish your shoot and then again push down the catheter with the curve to finish other sides. So this is one way. When it is going directly, you can just push the wire distally and slowly push it inside. So these are the two types that we commonly do. Whenever it is taking a loop, turning and going that side, but there might be some confusion sometimes whether it is going into a vertebral or into the right CCA. So whenever it is taking this kind of a turn and whenever it is going, it's most invariably it is CCA. So then you can push it down. So these are the types. So this diagrammatic representation is whenever it is taking a knot or a figure of 8 configuration, whenever you twist it, it does not go up. Sometimes you might be doing it for a procedure. So if at all you want to maneuver the catheter distally further into either, sometimes you might have to take a ECA shoot or CCA further. Then if at all you need to untwist the knot, then it goes slowly. You see that it will track distally. And whenever you try to take a wire, it goes. Whenever you try to push it with the knot, generally it doesn't go. The knot or the figure of 8 configuration helps when you want to push it distally into the arch. So this is one tip or trick that you need to follow, whether you need to take the catheter distally into the right CCA or whether you want to push it down into the arch. So how do you cannulate the left CCA? Multiple methods that we use. One thing is, if at all you are already in the right CCA, slowly push it and slowly try to pull it so that if at all it is in a very close proximity to the right CCA, it just hooks immediately into the left CCA. So this is one maneuver. And second maneuver is try to put the catheter, take a slightly LAO 15 or 10 or 15 so that it opens up the arch, and just try to take a road map so that you can visualize the left CCA well in road map. And then you can slowly pull the catheter up in roadmap guidance so that it hooks the left CCA. Or else, if at all it is not taking with an open SIM, then you need to form a figure of 8 configuration where it will turn and hook. This is one maneuver. So you can see that we have taken a roadmap and you can see the left CCA very well. And when you slowly pull the catheter up, it just hooks. And you can just untwist it so that it just tracks distally into the left CCA. So this is one maneuver. And also sometimes if at all your catheter has, you're forming a reformation in the descending aorta, you can with the curve slowly pull it up so that it goes into the left subclavian, left CCA. So this is the maneuver that we did. So the SIM has been reformed in the descending aorta and you slowly pull, it hooks into the left CCA. And when you further pull it, it slowly tracks into the left CCA. So this is one maneuver to cannulate the left CCA. And how do you cannulate the left subclavian or the vertebral? So one way is when you have formed the curve in the descending aorta, when you slowly pull, it automatically hooks the left subclavian. And also sometimes when you push distally, push it down into the arch from the left CCA also, it directly hooks into the subclavian. Either one maneuver can help you in different conditions. So when you take a shoot from the left subclavian, you can nicely visualize the left vertebral. If at all you want to selectively cannulate the vertebral, you need to use the wire either under roadmap you can just push the wire and directly push the catheter inside. Most of the times, if at all we don't need any selective vertebral, what we do is we tie a BP cuff to the left hand and we are taking the chute, vertebral chute through the subclavian injection. We inflate the BP cuff to almost whenever the systolic is coming till 140, 120, 140, then we push the injection so that itself gives us very good idea of the vertebral. I mean, it gives a very good images. So most of the times when we don't need selective angios, we do this. So here you can see that the SIM curve is open and you slowly, when you want, you twist it and make a figure of 8 and you see that it directly hooks into the subclavian. Now, if you slowly pull it towards you, slowly it advances further into the subclavian. From there, you can take a roadmap and if you want to say selective vertebral chute, then you can use the wire and then push it further distally. And this is one where we have pushed the wire into the descending and we have taken out the wire and then we are forming the SIM curve in the descending. Slowly we are twisting it now. Now it has formed the curve and directly hooked. It hooks into the subclavian. And slowly when you pull towards you, then now it is slightly, if you pull it directly, will go into the brachiocephalic and further going in. If you further pull, it will advance into the right CCA. So this is one more. When you're doing it from the descending, if you just open the curve, it has hooked into the subclavian. So right vertebral cannulation, how can you do it? If at all you're using a SIM2 glide, then number one, you can just, whenever you're pulling out the catheter, just put it, you can see the hump of the subclavian when you do it. You can take a roadmap from there. And this is the chute angio that you can take from the subclavian where you can nicely visualize the vertebral. If you have an images from the previous subclavian or vertebral, you don't need a selective cannulation. If at all you want, you can take a roadmap and you can pass the wire into it. This is the roadmap. Or else sometimes whenever you are advancing the wire, it directly sometimes cannulates into the vertebral. So you can see the difference when it was going into the CCA, right CCA, it was taking a slight small loop and then going in. So that is one differentiating factor when you can see whether it is going into the vertebral or the CCA. Often you might have this confusion. So what are the common complications that you can occur? Most commonly, sometimes we find the radial artery spasm. So what we generally do, we take a radial chute at the end of every angiogram or most of the angiograms, and we notice this kind of a thing. Commonly, we give some nitroglycerin at the NTG at the end of the procedure, or sometimes we place the catheter in somewhere in the brachial region so that whenever you're giving the NTG, it infuses into the radial part of it. And among almost 170 angiograms, we had one pseudoaneurysm which needed to be excised. So pseudoaneurysm is one problem that you can have. So if at all you're doing it from the left radial axis, how do you do it? So again, a radial chute, radial angiogram, and slowly you can maneuver the wire and catheter, reconfirm whether you are in the right vessel, slowly maneuver the wire, and you can also be sure whether there is any radial artery spasm. So now after taking the chute, it's the same procedure as we did on the right side. Now you can see the wire is making a curve in the ascending, hitting the aortic root. Then we are slowly advancing the catheter over the wire so that the SIM takes its curves and then it is ready to be maneuvered into the vessels. So for the left, you can see this is the left carotid chute. Now left vertebral, if at all you slowly, just like the brachiocephalic and the opposite side, just we'll try to approximate both the sides together, and when you pull it up, it generally advances into the subclavian, and you can take a angiogram and then push the wire end and then slowly push the catheter over it. And slowly you can push it, and if you turn and maneuver the catheter, it slowly hooks into the left common carotid. This is a common carotid angiogram. You can finish the angiogram, and slightly you will find some difficulty with the SIM2 glide hooking into the right brachiocephalic. Here I do not have the image of the right CCA, but you can see that we have taken a roadmap from the near the brachiocephalic in the arch, and slowly then you can through roadmap guidance, you can push it into the right brachiocephalic and also into the right CCA.
Was this a stroke case? There seems to be an M1 occlusion.
This one, sir, this I think was a normal angiogram, sir. Old stroke, we did a check angio.
Got it.
Yes, sir. So that ends my presentation. I just want to sir to share his thoughts and anything, any corrections or anything, you can just suggest your inputs, sir. Give your inputs, sir.
Sure. And yeah. So you guys are using nitro only?
Yeah, we are using only 100 mg. We give 100 mg of nitro, and we give only 1,000 of heparin. So we are right now not using any calcium channel blocker.
Got it. So I use nitro plus heparin 5,000 units.
Okay.
That takes away most of the embolic complications as well. The other thing is, if there is a rupture aneurysm, I only give like 2,000 units of heparin. But I almost always use nitro plus diltiazem. When I was in my fellowship, one of the sites used only nitro, but there did not seem to be a lot of differences in the vasospasm rates. One thing you can do is there was a vasospasm case that you showed almost at the end.
Yes.
In those cases, and that was also, this is the case. This also seems to be almost like an accessory radial artery. You can still do a diagnostic angiogram through this. If it doesn't go, if it's like a young female and she's like feeling uncomfortable, just remove the catheter and apply a nitro patch. There are nitroglycerin patches, which are good for these vasospasms. If you apply it at the site, it usually kind of diffuses, I guess, and then resolves the spasm. And then you can use a 4 French radial, 4 French SIM catheter to do an angiogram. That goes much pliably into these arteries. And when you're starting out, I'd recommend shaping the SIM in the descending aorta. I know it many times it just goes directly into the ascending. For some reason, I'm not sure why. In the Indian cases that I did in the last 3 years, was always going to the ascending and I was shaping it. But in the US, when I was doing it, almost always used to go into the descending aorta, or maybe into the descending arch. Maybe I was a little bit, trying to make it go into the descending, but we should always make an attempt to let it go into the descending arch. In some cases where you're not able to, when you shape the SIM in the ascending, it's a different configuration. And when it's in the descending, it's a different configuration. So if it doesn't work with one configuration, you can always try the other. And this month, our fellows will tell you most of our intervention cases were for some reason in the right common, right ICA territory. And we didn't even have to open a SIM select or an intermediate catheter. The wire just directly went into the right, and then we just followed it with the catheter. Many times, if the wire just goes into the common, just follow it, and there you can twist it into the figure of 8 and push it down so that it comes into the arch. Once you're done with the common or right ICA run, you can just come down, push it down into the descending and do a left common run. And I think Rohit was the fellow where I was pressurizing him. When you are doing the mini fellowship with me, I kind of, when I feel it's time, I kind of put a lot of pressure, and Rohit was able to finish a DSA at 2:00 in the night with just a Berenstein within 3 minutes. So I was like, go. kind of deal, and then he was able to finish it. So I think Berenstein can be used to the Berenstein I was talking about is like a stiff cordis Berenstein, not the glide Berenstein. So with the Berenstein, you can access right common in bovine, and also I guess you forgot to mention pseudo bovine arches. They're not exactly the bovine shape, but then they're the left common just arises very close to the brachiocephalic. So if you point a Berenstein towards that and send a wire, it will just go in. In the bovine, if the wire can just go in into the left common. In a pseudo bovine, you have to point the Berenstein tip. You talked about right word shaping. Sorry, you talked about left word shaping. You talked about the sim shaping can also be done in the vert, actually. You can shape it in the vert and then twist it into a figure of 8 and push it down so that it goes into the arch. Yes. And then you can just do a common right common, left common runs and finish the DSA. Carotid shaping, I talked about that. Berenstein, and if you really need to access the left vert, you can use a sim3. If you don't have a sim3, you can shape a 5 French MP into a sim configuration. And at that point, it depends on how much length you want, right? So you can choose the length, how long it should be. So it's a customized catheter. And then you can do a run. I think the left vert, selecting the left vert is a little bit more advanced technique possibly. Sometimes you just have to untwist and twist a few times, and just luckily it'll just go into the left vert. And many asked me about how to access the left common. If you just maintain the figure of 8 into the left vert and just jump into the left common, that's the best way to go about that. What was the reason for conversion in your 2 cases? One was
initially when we were using the SIM1, there was some difficulty of cannulating the left common carotid. So with SIM1. Yeah.
With SIM1, it's a little bit difficult in some cases, not in all. But SIM1 is also a great catheter. You know, if you're starting out initially, if you don't want to manipulate around the arch much, or if there is a lot of arch calcifications, SIM1 will give you better control to kind of minimize the movements, minimize the hitting the calcium deposits in the arch. So that's that. And pseudoaneurysm. So pseudoaneurysm formation, it happened to me once because I did a very high ulnar, like almost close to the brachial. I did an ulnar, and I expected it because that patient didn't have femoral. There was like a stent, like the TVAR, EVAR kind of stents in one of the, so we didn't want to go femoral. So we went high ulnar because the radial was taken away for CABG many years back. So, and I was expecting because there is no bone to, compress it against. So there was a pseudoaneurysm, but we applied very tight compression and it went away. In my fellowship, I think we had one pseudoaneurysm, but what we thought was like here in India, most of my technicians, we don't follow you should follow this patent hemostasis technique. That means after finishing up the angio, just apply the right amount of pressure so that the radial artery stays patent and you can do a lot more angios, a lot more procedures in that. Here we don't have we do have, but it's a lot less expensive when you don't use a closure device. So that's the reason I prefer snuff boxes for many of my interventions. And in those cases, you can just apply a very tight band and you don't have pseudoaneurysm formations in your snuff box, and you don't have snuff box typically doesn't close. But if you do use a big catheter to go through the snuff box, there is a chance of radial artery occlusion. But if you're maintaining minimal pressure, the patent hemostasis technique on the snuff box, which you can do without a closure device in the snuff box, so because it's a little bit easier. In those cases, you would not have issues. You would not have radial artery occlusions. But in my practice here, so I do have some radial artery occlusions. There won't be any present any symptoms clinically. So many times I was actually doing the left radial. It's good that I use you're doing some left radials. Left radial is a good way, especially for follow-up angiograms.
Yes.
It's like non-dominant hand, and even in the initial angiogram, you can do left radials. The only problem with left radial is if you're trying to access the left common, it's a little bit difficult unless it's a SIM3. If you want like a selective ICA run, it becomes a little difficult. If you have, in some cases, SIM3 helps, in some cases, SIM1 helps to go high up into the ICA. But the right side is pretty easy. And also you can buy, there are some cases of aberrant right subclavian artery. Those cases you can use left radial and just do fine. The bigger interventions might not be extremely possible, but then I use the SIM 6 French SIM guides, and that will just stay hooked up or anchored in the origin of the common. So you can take up your like an intermediate like Fubuki 043 through that, and then use a microcatheter. We have treated several cases or one case several times for vasospasms because there's only so many access sites, right? So I used the snuff box twice, radial twice, and then high radial, and then switched to left radial. I did the left radial for a few days of milrinone, and after day 8 or something, the vasospasm just broke by itself. Whenever I did the treatment would last for like several hours and then should start becoming weak. So in cases where you need multiple punctures, left radial is a great way. We actually published on the left radial access. What else? I think those would be my comments. Yeah, I think you guys are doing a good job. The fellows who are trained at Rajgiri who come to my place are doing pretty good, actually. You guys are already trained in radial. So if there is a second fellow, you are the ones who are teaching them, which is good. But we do have some advanced radial maneuvers that we are teaching to the fellows from Rajgiri while you are here.
If anybody has any doubts, you can just switch off your mic and you can ask your doubts. If at all anybody has any queries, any doubts. Right. Thank you very much for spending time with us, sir, and giving your valuable inputs. And we look forward presentations from you regarding thrombectomies, especially thrombectomies through radial access. We have started doing maybe small procedures through radial, but due to crunch of time, still we have not started doing thrombectomies through radial. We have done MMA embolizations, we have done carotid stentings, but still that initiation is not there. We have maybe done one thrombectomy radially, but we still had some sort of difficulty taking the solitaire up. What we did was we took a 6/7 slender and we put a 6 French envoy, and we took a 043 Fubuki, and we took a Phenom 21 and a solitaire. But the problem is that there was a great amount of resistance pushing the solitaire to the clot. So 081 we have ordered 7 French ready focus, and 081 Fubuki, 7F Fubuki. 7F Fubuki is out of stock. We are not able to get it. So some presentation.
I think I got all the 7 French Fubukis for myself. But we've done a case of covered stent for a CC fistula, and covered stents you need a very good support. In this case, we took the covered stent all the way close to the petrous, and then we sent a cat5 all the way into the ICA terminus, and then got the covered stent up. But we had some trouble doing it. But I think the main problem was the wire selection. We were out of our supportive wires. We used Chikai Black for these cases. We tried to use a BMW, that wouldn't work, and then we used a Synchro because that was the only one available. And I was a little bit annoyed with my staff that Oh, why didn't you guys order this before the case? I should have checked it. Always check the material before you start, right? But it didn't go, and then we had to use like a cardiac wire, and it went fine. In the past, we did like few more covered stents, and for all those cases, I think BMW and Chikai Black worked just fine. It's just this lady was like 85 years old and was torturous, very torturous anatomy. I think I posted that on the group. Very torturous anatomy. Went through radial. For the strokes, for basilar occlusions, I sometimes I forget, but many times, if you have a CT angio, just go to the side with the bigger wort. Many times, in some cases here, they're not doing CT angios. We're just bringing direct to cath lab. In those cases, you should just go left wort, left radial axis, left wort, and that's the most of the dominant words are the left words. And for bovine or pseudo bovine arches, radial is better than femoral when you're doing strokes. For some for some right-sided cases, radial is better, but in some cases, you would have these discouraging cases where the solitaire is falling down or whatnot. The balloon, for some people who are using balloon, I think I did a couple of cases with walrus balloon guided catheter, where we went through radial and deployed the balloon and did the thrombectomy. But this was like at the end of my fellowship, and I only did 2 cases. So I 1 or 2 cases. I can't comment on that. And walrus, I don't think it is available in India now. I think there is some guy in Paris using a 8 French radial sheath. I don't think it's radial anymore. I've never seen an 8 French radial sheath. So I think he just used the radial sheath and then went up with a flow gate balloon. Striker flow gate balloon, you don't need a 9 French like cello. For cello, you need 9 French. There is also a smaller cello, but then it goes through 8 French or 7 French. But for the bigger cello, the 088 inner diameter, you need a 9 French femoral sheath. So, but the flow gate is a little bit easier. You can use a smaller sheath. In our experience, I think we have done more interventions this month than diagnostics. And most of our cases, we used a 7 French Fubuki, and it just tracked up very beautifully. The 6 French Fubuki has some problems. The 8 French, the 088 inner diameter Fubuki has some problems, but the 7 French is really good. Soft, it goes up to the petrous, sometimes even more than petrous, but I'd recommend to stay at the petrous, not go too high up.
What do you suggest regarding stroke intervention, sir? Because we are well versed with radial. The temptation is for stroke also to, at least for the right-sided strokes, maybe the temptation is to go through radial. Is it? Yeah,
right side is easy. Left bovine arches are easy. The non-bovine arches, you should not attempt stroke, I think, in many cases, unless absolutely needed. But for strokes, in my setup, I need to balance the economy. So I use a 081, like the Fubuki 7 French 081 catheter rather than like a 088. And a Cat 5 and even a Cat 6 goes through a Fubuki 081. And you don't have to exchange the sheath for a 088 and all that to the radial. You just put a 7 French sheath, go through it with the 081 and go all the way up. There is also an Envoy 7 French, but the inner diameter is 078. I was disappointed by that because Envoy typically gives a very good support, more support than the Fubuki, but the 078, I don't think it will fit a Cat 5 or Cat 6. So.
And your procedures also, you have not used, and most of the procedures, I've been tracking almost 27 to 29 procedures that you have posted in WhatsApp. So maybe once you have used the stent retriever, that would Trevo you had used. For most probably you are attempting aspiration. Any particular reason for that?
To keep it low, to keep the cost low. It's ADAPT technique. I use it twice. I've been meaning to publish it, but there's the Fubuki 043, right? Sometimes I just deploy the stent retriever through that. I just go past the occlusion, deploy the stent retriever, and then apply suction in the Fubuki and also in the intermediate, like double suction. Sorry, in the bigger catheter, not the intermediate. Fubuki is the intermediate, and then The 7 French Fubuki would be the bigger catheter, and we applied double suction and stent retriever at the site of the clot. That was giving me good results, but then I don't have a lot of cases. This month we did about like 4 thrombectomies. But yeah, that's where we are.
And what do you hear about this wrist, sir? Is it a game changer for at least for radial?
That's what my friends keep telling me. Medtronic, right? Medtronic is coming.
Medtronic on the wrist.
It was going. So wrist is like a 081 again.
Yeah.
So it's similar to the Fubuki 7 French. And most of my friends. So in the US, the AHA guidelines state that you have to use a large bore for aspiration, either a large bore or balloon guide. I'm not sure if this 081 comes under the definition of a large bore, wide bore, but still many of my friends who are trained in radial at the same time as me, they're just using a wrist catheter, like a 7 French sheath wrist catheter, then going up all the way into the, ICA terminus, and then using a red 62. Red 62 goes through it. Okay. Again, what else?
Red 62, it goes through also 7F Fubuki also, right, sir? Yeah,
it goes through that. And they were also using a Zoom 64 or Zoom 58, 55 something. Okay. There is a Zoom 55, Zoom 71. There is a catheter in between that, I think. So they were using either that or a Zoom 55, and they were having very good results. Okay. These are like cases who get TPA, 85-year-old, 90-year-old cases. So yeah, I stopped posting many of my cases on the groups because it was getting repetitive. But the people who come here, I'm training them, and they're doing a good job.
No problem. So we are following all your cases closely. So it will be helpful. Maybe not for the senior group, at least for us, it is really helpful. We see all the material that you have been using, so it's of great help. Maybe if at all not for this presentation, I was about to message you to keep posting all your cases because it's of great help.
Sure, I'll post them then. That's fine.
Sure.
We did like 10 carotid stents this month, couple of aneurysms, and then 1 covered stent. That's it. The diagnostics are, well, I don't remember doing diagnostics because the fellows are doing the diagnostics. That's the reason, I guess, I don't remember doing diagnostics, but yeah.
Sure, some presentation of procedural presentation will even be of great help, sir. We have seen your transradial carotid stenting. That's like a broad this thing. Maybe some procedural stepwise this thing would really help people like us. Maybe a thrombectomy or also a carotid stenting procedure, like proper hardware. So
sure,
it will be of great help.
I'll post them.
Sure, sir. So thank you very much, sir. Thank you very much for joining us, giving your insights and sparing us time. Thank you so much, sir.
Take care now.
Thank you. Thank you.